illness-based, right? Sure.
And infection.
Yeah, infections on the list. And I don't think I really expanded on that, but does that surprise anyone with infections on that list?
No.
Why? In the United States. It's on the list in the United States. It's not in the world.
Because even though we like to think that we do good and we're sterile and clean, we're probably not as much as we think we are.
Okay.
Yeah, I feel like infection causes a lot more issues in our country than anything else.
But I think that's a shame,
Yeah.
considering
Yes.
how readily available we have all these infection prevention measures. I think, when I think of countries that don't have what we think of as good healthcare resources, that's where I would think that infections are supposed to kill people. So the fact that it's in our top 3 is insane to me. Okay. Anything else you got out of the lecture yesterday about infant or maternal mortality? Infants is trending down.
The main,
What about the birth weight?
Our
birth weight, causes an increase from
It is believed that one of the reasons we have such a high infant mortality rate compared to what we should have is because we have a relatively high number of very low birth weight infants in this country. So if you took nutrition, you may remember that we had a lesson about pregnancy and birth nutrition and lactation and newborns. And one of the questions was about how birth weight is the child's birth weight is one of the single best indicators of long-term outcomes. Which I think, when you first think of, is like, what does that matter? But when they tie childhood diseases and health to all sorts of things, what their home life is like, their level of education, the parents' education, birth weight, were they breast or bottle fed, yada, 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 that birth weight keeps coming up as an important factor, which is one of the reasons something like WIC, which is a federal nutrition program, is around. You're catching women at their childbearing years through a pregnancy and then a child in the first 5 years of life. Did you have your hand up?
Yeah, would you say like the low birth weights are ones that are like coming towards our turning up or just in general?
That's a good question. So a couple people yesterday were kind of trying to ask that same kind of question because it does get confusing. Because yes, of course, having babies born early, of course they're going to weigh less. However, when you hear, have you guys heard the term that baby was large for gestational age or small for gestational age? Okay, that's just like have you guys seen those growth rainbow charts where you plot out height and weight and your child is in the 55th percentile for that yada yada. When we call somebody a baby small or large for gestational age, it's because on that rainbow that was plotted of all 40-week babies or 41-week or 24-week, they're in the lowest 5% or above the 95th percentile, small and large. So that's taking into account their weight as compared to how old they are. When you hear the term low birth weight or very low birth weight, they don't care about how old it is. They're just talking about the sheer number of babies born below 3 pounds 3 ounces or 5 pounds 8 ounces. So yes, I think like a baby being a preemie is going to affect it, but there's other babies that are not preemies or shouldn't be that small that's impacting it. And I think those are the ones they're really looking at. Because of course we know if we're going to deliver a 25-weeker, the biggest we're going to expect it to weigh is maybe 2 pounds. That's normal for a 25-weeker. But when a 34-weeker weighs 2 pounds, that's a problem. And those are the factors they're looking at with nutrition and the health of the mom.
You said that 5.8 is low and then very low.
Yes, so yeah,
Okay.
they go by grams, so it's 2,500 grams is
Yeah.
low birth weight, but that's roughly equivalent to 5 pounds 8 ounces. Very low birth weight is 1,500 grams, which is roughly, I think it said 3.3 pounds. So 0.3 of a pound would be like 5.3 ounces. So, okay. Anything else about mortality stuff that we talked about? What else did we learn about why, you guys told me which ways they're trending, but what are some of the other problems with our statistics?
Ours are higher than other countries.
Yes, ours are much higher or worse than other countries with similar birth rates and oftentimes with seemingly less resources. So that's a problem.
And it's our maternal mortality is like going up rapidly. Like the last
Yes.
2 years have been a lot higher.
It was kind of tapering off, and then the last two, it shot up again, like 3 points apiece. What else did I say is the problem with our maternal mortality rates? Yes, about 60% of them are preventable. So when you think of something like 20 women for every 100,000 live births, I think we can sort of idiotically think, that's not that much. But here's what I think, that's 20 babies who don't have a mom. And think of all the repercussions not having that important role in your life from the beginning is. And then think about that baby's other parent, or the rest of the family, or all those dynamics. So there's a ripple effect. Okay, anything else? Okay, so we'll finish up this topic. Now I wanted to talk about the maternal mortality rates are getting attention. The other sub-topic of that that's getting a lot of attention, as well it should, is the disparity across racial groups with maternal mortality. Okay, so let me give you a couple of numbers here. Okay. Okay, so look at, you guys can see the color differences here, right? Okay, so Hispanic is this dark blue dotted one. Asian Pacific Islander is this solid light blue one. American Indian Alaskan Native is this lighter purple one. Black women is the darker purple, and then white women is this dark blue dotted or dashed line. Okay, and then it's broken into age group. So if you're less than 20 years old, 20 to 24, and then those of us that are old moms over here. And it's showing how many pregnancy-related deaths per 100,000 for each of those racial groups. Okay, so what do you notice?
It increases as age gets older.
For pretty much all of the groups, right? So yeah, now notice these two, doesn't it increase steeper with age than these three? But they all go up in some degree, right? Okay, what else do you notice?
The two purple ones are older to start with, and then
Oh, you mean higher, yeah, the number of deaths. So the maternal mortality rate, this is the rate. There's start higher, and then look there. Okay, I don't know why they did that, yeah, or maybe there aren't as many that give birth. I don't know, that's a good question. No one's asking that.
A lot of times when that happens, it's because they can't put data on there that would target somebody. You'd be able to tell if you lived in that community who it was. So they have to totally throw it out. So if there's somebody in a small Inuit community that's 40, then they're gonna know, okay, that's Betty, and they have to completely toss that data out. So a lot of times with Native American and Alaska Native, they don't have enough population to make it a good data set.
Well, yeah, I don't know if they target certain ages themselves as a population. I don't know that part, but that's a good question. And this is CDC data, There should still be enough to some statistic. Okay. So what this graph is showing us is what's going to match the statistic I'm going to tell you. So, and this has caught the attention of a lot of people now, which is good. So, what has existed for well over 50 or 60 years is a significant disparity of maternal mortality rates of Black women versus other groups. Now, typically in the US, when they were starting to do these statistics, they typically focused on comparing Black women and white women, okay? This one shows more groups. But for 50 or 60 years, consistently, the maternal mortality rate for Black women has been about 3.5 to 4 times higher than white women. And if you look at this, I mean, that matches. Because here's 40. Like if we say the white women in their 40s, they about 40 of them die per 100,000. Black women are up to 180. So that's over 4 times. And now it's obviously look at how much it drops for between ages, so you can compare. But this is displaying what I just said. Okay, here's the part that I find, having been to grad school where you do all these research classes, I'm one of those people that thinks, oh, there must be what's the reason? If we find the reason, we can fix it, right? But here's the thing. A lot of times when outcomes of any disease process are different amongst ages or races, what do we think of could be the cause of that? If hypertension rates are different in Black people versus white people, or what do we sometimes think might be the cause? Genetics could be one.
Environment,
Did you say that? Okay, what do you mean by environment?
where they live, their access.
Okay, so socioeconomic status, right? So how wealthy they are, access to healthcare, okay? What's another big thing that we tie to health outcomes? Think about what we're doing right now.
Oh, education.
Level of education, okay. So here's the thing that's always stuck with me when I teach this content, is that these differences have existed, again, for decades, irrespective of education and income. So even if we put all the races that make the same amount of money in the same study, you're still going to have these differences. If you focus on income classes. Okay, what does that say to you guys?
Racism.
What'd you say?
Racism.
Racism, okay?
Or lack of availability for those communities.
Okay?
The cost to get extra help, because some of these people don't have insurance or no way to get insurance.
But that's the hard part too, is what I find thought-provoking is even with income controlled for. Even if we compare all wealthy Black women and white women. So let's say access to care is not an issue. Why do these differences still exist?
Like an environmental aspect of it as well, just the community looks upon different things in different ways. So,
Okay.
if you're having these symptoms, it's not a big deal, whereas other communities do.
Okay, so you think perhaps there's differences in when we seek care or when we go to get care, okay?
What about a general distrust of the medical community?
So when you read about this topic, that is usually brought up, there can be some distrust. Why?
Because of terrible experiments gynecologically done on Black women.
Okay? All right, I think you guys all know that this type of issue does not have one cause. But what else is getting a lot of attention right now in regards to health disparities across races? It's kind of fascinating. They're really looking at something called epigenetics. You guys know what that is?
Switching on and off of genes.
What'd you say?
So the switching on and off of genes generation to generation.
Yeah, so the reason I'm focusing on this, guys, is because this is big. You know, it's not like a little higher. This is huge. And even when you account for income and education, this is the other one I want to show you. Look at this one. Look closely. So this has got white women, Black women, and then American Indian, Alaska Native. And it shows some education differences. Look closely at this. Mhm. What do you notice?
Black women are still the highest in every group.
Mm-hmm.
And it really doesn't decrease that significantly for them, whereas, white women, with our education.
Well, I see white women with education, it goes down. But, I mean, yes, from here it goes, but look at how high these still are. What I find poignant is how much different the disparity gets. That's what doesn't make sense to me. Like, if for some reason in my mind it seems backwards that as you get more educated, I would think these would close. But that's also a faulty logic, right? Because that's assuming that education is the cause. And do you guys agree, or do you see what I'm saying? Okay. I find this one very thought-provoking. Okay, so listen, there's a lot of focus now. I mean, there's been a focus on genetics for a while, but now what they're focusing on with epigenetics is they're realizing that health disparities and health issues are not just from your own body and your own life. That you could almost think it of like miskeyings or misfirings happen generationally based on trauma experienced by a group of people or even within families. So when you study trauma and abuse and things like that, you can find that subsequent generations may have worse health because their mom, their grandma, etc. had traumatic event after traumatic event, and it altered their DNA. Some of the earliest studies about this topic, when they look back at DNA for people during the Civil War, there's significant changes prior to the Civil War and after the stressors of the Civil War, especially within Black people. And then with OB, they're focusing a lot on how, what did we just talk about? Our outcomes are getting worse in this country for all childbearing women. They're focusing on how much of that has to do with how unhealthy we are now. It gets passed on to the next generation. Does that make sense? It's high level biochem type stuff, but after they studied this for a long time, because the other thing I meant to say is if you go to other countries this does not exist. So, I think Sarah, you were the first one that said genetics. Yes, we know that there are different amounts of cystic fibrosis or sickle cell or hypertension in races, we know that. But if that's accurate, if that's just the cause, it should be the same around the world, right? This is a different issue, exacerbating. Questions, thoughts, comments? No one? You guys are quieter today. This is a tough topic, but I think it's an important topic. Any area that you work in, disparities within that are important. And it's going to take a long time to turn this around, but we can't turn it around by not talking about it. You guys know who Serena Williams is? Okay. She has a story of when she had her baby. I think she had a C-section, but she ended up having a DVT, and no one would listen to her when she complained about it. And she's famous and wealthy. So I think that's an example of where some of the distrust may come from. Again, it's a complex issue, but it's something that we're gonna have to work really hard to improve, just like we will with our overall outcomes for moms and babies. Yes?
How does this relate to, I don't know if it's just, I don't know what to call it, but the idea that when pregnant women complain of pain, it's almost like tough it out. Compared to other races, when they complain of pain, people pay attention.
I think that's kind of what the Serena Williams, I mean, I think that's what she was trying to say, is they wouldn't listen to me. Is it because I'm black? You know, that kind of thing. But there's a lot of misconceptions about, cultural responses to pain, family support, and how we all process hospital stays. I think that's absolutely part of it, and then I think that creates a distrust, you know, so it's kind of cyclical. Is that aligning with what you're talking about?
Yeah.
Yeah.
It doesn't matter whether you're wealthy or you're educated. One of the first people to suffer from monkeypox, he works for the CDC dealing with monkeypox, but nobody would believe him that he has monkeypox, and he's a black guy.
He's a black guy?
Yeah, they ended up diagnosing him with monkeypox by mistake, but it had been almost a month.
Ah.
And
And nobody will listen to
no
him.
specialist, and he has connections to the best doctors. Nobody would believe him.
With OB too, I mean, this is just Central Missouri, but there is one black provider at Capital Region who's phenomenal. But Columbia, that's huge, I didn't know this till I saw something on social media, there are no black OBGYNs to deliver babies. So does anybody know who Dr. Courtney Barnes is at Women's and Children's? She's real into like pro-patient, pro-change the landscape of everything. She got, I think, a $10,000 grant or raised $10,000 to train 10 black doulas. Do you guys know what a doula is? It's like a birth attendant. Because her point was, look, if we don't have any of the actual delivery providers, why don't we put money into having some black doulas? And because our patients were saying nobody looks like me. She also does group prenatal care, like 20 women in a cohort that are all pregnant about the same time. She'll do her prenatal care that way, so that they all get more time with her than each getting 5 minutes, you know, that kind of thing. So she does lots of really neat stuff, but that's getting launched in Columbia. So it's a step, it's an effort, you know, to help possibly bridge some of the gaps with OB care, at least in Columbia. So, anyways, now that we've talked about these topics, listen for news articles, things on, you know, just Let me know if you see anything, because I feel like we're seeing more widespread efforts to deal with these disparities, both the racial ones and then just the awful maternal mortality rates that we have in this country. So, okay. All right, let's talk about some legal ethical topics related to OB. Patient rights, we know that's important everywhere. Some of the topics related to OB is, you guys may have heard of this, but a lot of patients will have something called a birth plan. You can print them online, you can click your big, like what you want, but they'll bring in their birth plan, and it's kind of like their wish list of how they want things to go. Who they want to cut the cord, do they want a mirror to see everything, do they want anesthesia, all kinds of stuff. So those are guidelines for what they want. Also, a really tough topic with patient rights is that we sometimes have to struggle of balancing the two patients and what's best for them. They both have rights, but during labor and delivery, you know, we're still trying to separate them out, and so what's best for the baby may not be what the mom wants. The team may be saying, we need to do a C-section now, and she may say, I don't want one. So she needs to understand what that could mean for the baby.
I have a question on that. If the mom is just insistent on not having a C-section, I hate to ask this question, but does somebody step in and say,
Yeah, they have a
you
legal
have
team.
to, or,
They can get legal involved with the hospital, and
will they force a C-section?
they could. It doesn't happen a whole lot,
Okay.
because usually you can convince.
I was gonna say, I think once you educate them, because my sister was her first baby, she didn't want to have a C-section. They told her she needed to, and she didn't want to because she felt like she wasn't
Right.
doing it the right way or gonna be like a mom the same way. And so once they like told her, obviously she did. But I feel like a lot of times they're just scared in that moment.
Well, a lot of times, you know, it's the fetal heart rate that looks bad, but the mom feels fine.
Yeah.
Well,
You know, it's kind of like telling someone they have type 2 diabetes and it's awful, but they feel fine. They're just like, okay. They don't think it's this critical thing, whereas when we know how to read fetal monitor strips, we could be like, this is a crash and burn thing. Yeah.
I think I'm thinking of like Christian Scientists in that realm where it's against their.
I mean, you cannot, I believe that usually the way it will go is if you have to get the legal team involved, you would have to believe that she's not in her right mind. That is very rare, but it does happen. Usually it's sort of more of a stubbornness, and once you explain, but in that regard too, when I was talking earlier about preemies, like 24, 25, 26 weekers, that's also a very difficult time because the neonatologist and the obstetrician are going to be playing this game, because every day that you can keep that baby in is way better than putting it in a NICU. But if her health is suffering for whatever reason, you have to be very careful. So that's often something they're also balancing very closely with those moms that are having pregnancy complications. Okay. HIPAA, you guys are aware of what HIPAA is, correct? Okay. It can be challenging in these areas. Why?
It's so small.
So what?
Like it's such a little area that everyone knows everyone anyway.
Everyone knows everything?
Yeah, like everyone knows everyone, so.
So if you were to post about, oh, this person was having a birth today, then everybody would.
Oh, I'm sorry. You're talking about on social media?
Kind of, yeah.
Yeah. Why would it be hard in the hospital though? Like respecting HIPAA at all times, working on this type of floor.
If something bad were to happen to like a child, you would want to talk to like somebody else
Yeah.
about it.
There's a lot of different units that sometimes have to be involved. You might have a cardiac unit, and then your urology unit, and then you have the open unit. There's so many.
I was kind of thinking a little more uplifting. I was thinking about how you guys are being really
We're
negative.
just in the dark.
You are, I'm like, whoa, yeah, I guess so, sure.
Do you mean like we're excited and we go and tell everybody?
Yeah, that's where I was going for. So it can be really hard. I remember, you know, when you have someone for 12 hours and it's almost into your shift and they're about to deliver, the grandparents know you're the nurse for that room and they've known you all day. So if we kick them out and say, we're gonna start pushing, and they're bursting at the seams in the waiting room, and they come back out to the desk and you helped with the delivery 20 minutes ago and you're charting, and they see you, they're gonna wanna be like, so was it a boy or a girl? You know, they're gonna ask you all that stuff and it is so hard.
Okay.
It's a good challenge, but it's, the other ones I've seen that can be really difficult is, depending on how the floors are laid out, if it's a C-section baby, sometimes they'll take those babies to the newborn nursery to get admitted. And if that's not close by, and it's a delivery where they didn't know the gender, that little pink hat or blue hat tells a heck of a lot that they just waited 9 months. So you have to be very careful about which passageway, you know, just little things like that. And then what you guys were alluding to, I'm glad you brought up, it can be very difficult as a student getting to see these really cool clinicals to want to get on your social media and say, oh my gosh, I had the best day ever. It's my favorite day I've ever had in nursing school. I saw a C-section delivery of twins. Oh my gosh, it's amazing, yada yada. Well, like somebody said, it's not that big of a town. Columbia is a little bit bigger, but it is not hard for several people to see that post and know exactly what you're talking about. So I would make sure that you don't post anything with details.
You could just say C-section delivery, right?
I wouldn't even say that.
I wouldn't do it, I'm just trying to like.
I would say, you know, nursing school is going great. I'm enjoying OB. It's neat to see births. I mean, you can do, I know that's not just a topic. I wouldn't say gender, I wouldn't say route of birth, I wouldn't say hospital. I wouldn't do anything that somebody could figure out what you're talking about. And it's not to take the fun out of it, it's because literally, you guys ever heard like, you could be talking on the elevator to somebody and the one other person on there knows who you're talking about? Like, that's kind of how I feel like Central Missouri can be. So, it's to protect yourself because you don't want to get in trouble. And when you're in clinicals, be careful because family members will try to inadvertently just be like, oh, how's she doing in there? And you could be on an endorphin rush from just watching the delivery and want to talk all about it because it's amazing. You can't.
If someone asks that, are you allowed to say anything or just?
I usually will say, oh, things are going fine, or if it's anything specific though, I tend to just say, I'm not allowed to talk about it, I'm sorry. I'll make sure, as soon as we can let somebody in, we'll make sure you can come in and then the family can tell you. That's typically what I say. And then once the family tells them and you're in there and then they might say, oh, how much did he weigh? How, like, did he pee yet? I mean, and the family's okay with you talking about it, that's fine. But, okay. Okay, scope of practice, just like anywhere, you're going to be working as RN students, but even if once you're a full RN, you need to know what you're allowed to do within the specialty. So typically, nurses are not allowed to break water on a patient. When they have internal monitors, depending on the facility, some facilities let the nurses place those, some don't. So you just need to be aware of that. Okay, standard of care and negligence. What do you think of when you hear the term standard of care?
Yeah, so
That gives a baseline for how you take care of every patient.
Okay, a baseline for how to take care of every patient, sure. What else?
The care that's required,
What'd you say?
the care that's minimal or required.
minimally required? Okay, sure. So avoiding negligence is important everywhere in healthcare, and holding yourself to the standard of care is important everywhere in healthcare. But I do want to point out that it's especially tedious in this area because this is an especially common area for lawsuits to occur. And why do you think that is?
It's how fast-paced everything is, like,
Good thought, but not the number one reason. Why do you think this is an area where there's a lot of big lawsuits?
I think things go wrong, you just can't predict them.
Okay?
such a emotional time as well.
Doesn't everybody want a perfect birth and perfect baby? And are we good at settling for anything less than that? No. This is, and it's a child. It's a child to a family, right? And a lot can go wrong. And so, even if everyone does everything right, stuff can still go wrong, right? We know that. So, the reason I bring that up is that's where the standard of care comes in. So the standard of care definition is the level of practice of a reasonably prudent registered nurse in the same or similar circumstances. So the standard of care is a level of practice of a reasonably prudent RN in the same or similar circumstances. Okay, so what that means is if a provider, a nurse, a doctor, any professional in this area does have to go to court, they're going to look at, were your actions fitting if another RN that's prudent was in your shoes? Did you do what you should have done? And again, sometimes we all do the right things, and there's sometimes bad outcomes. I think we often want to think that if, I think as a society, we think if there's a bad outcome, somebody screwed up, and I'm gonna find that case. Which I understand that logic in a way, but there's not always something that did go wrong. Things don't always go perfect, unfortunately. And this is just a very high acuity area because you're dealing with new people and you're building families. So, something to think about. Okay, and then sentinel event and failure to rescue. I'm just gonna mention a couple of sentinel events. First of all, do you guys know what sentinel events are?
Yeah.
What?
Death.
Well, not necessarily.
It's like an event that isn't.
Some people call them never events. They're things that should never happen.
Unexpected.
Or
Yes.
things that can be prevented or no?
You guys are asking good questions. I'm not prepared for it. Usually when you hear the term sentinel, it is a big bad event that should not have occurred. Okay? Oftentimes because major errors occurred. Occasionally, they'll always investigate them, and occasionally no one did anything wrong, it was just a bad occurrence, but they will investigate. But oftentimes, something went wrong. So I'm gonna pause for a minute, run to the restroom. You guys can take a 5-minute break.
The teacher was saying you're quiet, now asking her questions. I can't make it a small one. Yeah, I know, when you look at it, I think you should have really.
Yeah.
You have an addition?
Maybe your classmates will be so hard to make it
Girl, I can't hear you. What?
In a healthcare setting that results in death or serious physical or psychological injury to a patient not related to the natural course of the patient's illness. So I think Sarah mentioned death when I first brought it up, and death in and of itself, we often see coming, right, for fitting reasons for a patient. But it would be a sentinel event if it was someone who wasn't supposed to die. You know, they went in for a simple procedure and died. That's a sentinel event. Something went awry. One of the biggest, most obvious ones in OB that, dear goodness, I hope don't happen anymore, is when two babies are switched over. You know, discharging the wrong baby to the wrong family, big bad sentinel event. So the couple that relate to this specialty, a maternal death. Now, I've been sitting here telling you guys how high our rates are, but it's still relatively uncommon. It's less than 1,000 moms per year in this country. So, when one does occur at a hospital, it's a sentinel event. It needs to be investigated deeply to figure out why. And just, was there a failure to rescue? You know, what happened? And it doesn't necessarily mean somebody messed up, it just needs to be investigated because it's such a rarity. And we like to believe that childbearing women should not die from that process, okay? So maternal deaths are sentinel events. A severe bilirubin level in a baby.
High bilirubin?
Well, a severe one. So when you start to get to like the 15, 18, 20s, that's becoming to a level it can cause neurological damage, and those should not happen. Oh, I mean, the lights usually start taking care of it. With my son, they started having a supplement with formula, because formula can help flush out some of that billy. If it's a true, like, ABO incompatibility, they'll sometimes do blood transfusions, but that's incredibly rare. But usually the lights take care of it. Yeah.
Two of my girls had it.
Yeah.
We just, like,
I remember our pediatrician saying it's like one of the most annoying things with babies, because it's like, we don't know why, and it doesn't have a purpose, like.
yeah.
And I keep thinking at some point, maybe there is a purpose, like maybe it's something we haven't discovered yet, like, but why is it so common? What, you know, so, yeah. Okay, and then I already said an infant being discharged to the wrong family. And then another one, it's kind of like the maternal death, but anytime there's a neonatal death of a baby over 2,500 grams, that's a sentinel event.
That was the 5 point something.
Correct.
Okay,
Yep,
just
5 pounds, 8 ounces. Good job, guys. Slowly but surely, all these things will start to interconnect. What'd you say? 2,500, yeah.
But any death?
Any death of a child born weighing more than that.
Is that just because they're healthy and?
Yeah. Now, I mean, it's possible, you know, they weigh more than that, and we know. I took care of a family one time, the baby didn't have kidneys. I mean, they knew it wasn't going to live, but it was born looking just like any other baby. So I don't know that they would have to list it, but they would quickly know we know why that child's gonna die. But because it's over 2,500 grams, it's relatively rare for that to happen, so they would just need to investigate. Okay.
What
about for like the stillborns that they have no idea?
You mean when they're delivering a deceased baby?
Well, like,
Maybe
yeah,
they know.
since they'll.
Maybe like.
They'll usually, so the only ones we don't know about are when they come into the hospital as a triage patient and they say something like, I haven't felt my baby move. If we discover it deceased, that will not be a sentinel event, only because the death occurred before it was in the hospital. Now, will they do an autopsy and investigate? Yes, they may do that, but that's different than a sentinel event where, with a sentinel event, you're basically implying that something in the healthcare system malfunctioned. Or probably did,
Like
maybe
some,
not.
yeah, some of them can be prevented and just not emergency.
Oh, yeah. That's why you often hear failure to rescue. So this is how old I am. I graduated nursing school in 2005, but this was a big focus then. And that's when, have you guys heard of rapid response teams?
Yeah.
Were first becoming big because they were realizing that, nurses would call doctors at home and no one would listen, and they would call and they'd not document a note, and they would, and all these things where somebody eventually went into a crisis, they saw hours before, they saw deterioration, but we waited until there was a crisis to actually do something big, and by that point it's often too late, we failed the rescue. So they started creating these rapid response teams in the hospital because they wanted, and nurses could call for that. You don't have to have a doctor's order. But it was to help catch these things before things went bad.
Even families.
Some places will do like a family one, but when they first started, they were mainly for nurses to use. But I have seen some places where there's a number for family to call.
As if everything's
Yeah.
in Colorado.
Yeah. So, and I don't know if that's like a slightly different one, or if it's the exact same one, but they may have like a customer service one, and they may have like a healthcare team one. But either way, I think that's a genius move too, because how often are we not in a patient's room? And they are. Okay, I already alluded to the maternal-fetal conflict. That's a unique struggle that we have in this area, is oftentimes they're still connected by a placenta. And so we have a conflict of who's more important, who do you take care of, who gets priority, and making the best decisions for the health of both, and trying to also be patient-centered at the same time. Okay, informed consent, I think you guys know what that is, correct? In OB, many of the informed consents that we do, well, why don't you guys tell me, what do you think are some of the informed consents that we do in OB?
An emergency. Anesthesia.
Anesthesia, yeah. Just to have an epidural and then a vaginal delivery, to have the epidural placed, you have to sign. And you have to inform them of the risks ahead of time.
Emergency C-section.
Any C-section, even if it's scheduled, a non-emergency, that also needs informed consent. What does informed consent usually involve? Like, what are the things that are part of that?
What you're gonna do.
So what the procedure entails,
What risks.
risks. What's the other big thing?
Release of responsibility.
Well, that'd be nice, but alternatives. If you don't have this, here's what can happen. So you have options, here they are. Here's the risks of the thing we're offering. A lot of times, we are involved in getting the consents signed, but typically, like, the anesthesiologist will come in and talk about the informed consent for the spinal or the epidural. The provider, the obstetrician will also often tell them, a real quick summary. I tended to always, I learned this from my preceptor and I never forgot it. Anytime we would have a laboring patient or an induction, I would always explain way at the beginning, while everything's going well, what things that if they happen could lead to a C-section. Because most people don't have a C-section planned, and if it's not part of the plan and we have to go down that route, it doesn't usually do a good job lowering anxiety. It usually just goes through the roof. But if you can tell a mom way at the beginning, hey, everything's going just fine right now. We expect things will go well, but in case this happens, etc., you may see multiple people come in. You may hear us talk about this, and here's why we will be talking about that. I think that is such a proactive way to educate, instead of waiting until there's a crisis and try to roll someone down the hall while they're signing, while they're afraid something's happened to their baby. Okay, last topic on this slide is something called allocation of resources. So we've already talked quite a bit about how good our healthcare system is at allocating resources, right? Okay. There's a couple of unique topics. I mean, every specialty area has topics under allocation of resources. But here's a few I wanted to run by you guys, and you've been relatively talkative so far, so I'm expecting quite a bit from this. None of these topics have right answers. They're truly, in my opinion, conundrums. But they're expensive treatments, and as science advances, it's a difficult discussion of how do you allocate these resources. Do you only get these things if you can pay for it? Should insurance pay for it for everyone? How does that work? So the first one is, what are your thoughts on healthcare putting money into women getting pregnant after menopause? Are you saying, who would want to do that?
I'm just thinking, I'm the only one that's in that age, and the thought of having a baby makes me just want to poke my eyes out.
Are we talking public or private funds?
That's what we're talking about all. Because obviously if somebody has private funds to pay for something, they can probably get that, but then other people would say, well, that's not fair. You know, why does somebody get access to this just because they can pay for it, you know? Sarah's still looks at me like I have
I think you're
7
just kind of setting people up for failure. You know, and all the risks go up, maternity and mortality goes up, infant mortality goes up.
But Sarah, I want to have a baby at 53.
Adopt.
Why would you stop me by telling me those things?
Public good.
No, I want it. I finally got the man of my dreams.
Oh, that's great.
After the first few failures. Why are you stopping me?
Keep
I
trying.
mean, yeah.
Keep trying. Good luck.
You guys see why I'm saying there's no right answer?
Right.
Like, I mean,
I sound so mean.
as clear as you think this is, somebody else
Oh, yeah,
would be like,
of
but it's my
course, of
right.
course.
It is my right and it's my body. That's the way we talk now,
I
right?
feel like if it's their right and they have enough money to do it themselves, they should have to.
So what do you say to the people who don't have enough money? Why shouldn't they get that? That's a lot of times what gets tough about healthcare.
I mean, if you're like 50-some years old, like, I don't know. Probably shouldn't have a
This
baby.
did happen though.
Oh yeah, there was a 57-year-old.
That's right, that older woman a couple years ago, and the doctor's like,
There's
what's
like that
wrong with
grandma
you?
that carried
Yes.
her granddaughter's child or
Yes, yeah.
Okay, so that's
It's
one.
publicly paid for.
What do you guys think about insurance covering elective procedures such as epidurals, circumcision, and in vitro fertilization? Should insurance, especially state-funded insurance, that's usually where the big kicker is, should that be covered for everyone?
Yes.
Okay, why if they're not necessary? Where do you draw the line? If we can so easily say yes to those things, why can't we say yes to the fertility? I mean, that's the hard part. Is some of these questions, I can see you guys very quickly come up with an answer.
Yeah.
But then the next question is, okay, where do you draw the line?
Who decides what's elective?
So usually when we use the term elective, it means it's not essential. So I'm thankful I had an epidural when I had babies, but I did not have to have it in order to have the babies.
That's all I was saying, like, who decides that it's not essential? Because for someone, it could be essential.
Yeah.
Especially something like that.
An
A
epidural?
a circumcision could be essential for someone.
Think about back in the day that they.
Usually for babies, though, circumcisions typically were not viewed as essential, typically.
Unless you're
An
having a breast,
epidural
even then
is
there's no,
Unless you have what?
unless you're
For
Jewish
newborns
we have a
though?
bris. Sorry.
Because a lot of times
Yeah.
older men,
Yeah.
or they'll have reasons they, yes, they'll sometimes have reasons to, but most men don't want to have one at that time, which is why I think they often opt for their children to. Okay, so any other thought, what about IVF? IVF's really expensive, right?
I know some insurances only cover it like the first time.
Mhm. Some don't cover it at all, some cover everything.
So can I tell you some legislation that's coming down Missouri?
Sure.
Missouri right now is trying to, there's groups, and you can, this is gonna be a hot button topic, but Missouri is saying that they're gonna start illegalizing it because,
Oh wait,
You
all of
have-
IVF?
yes, because you have to be okay with terminating births in case there's multiple.
Oh.
And so now it's like, okay, but if we're paying for this, then we're also gonna be paying for the repercussions if somebody has 10 fetuses that have developed.
That is a very difficult.
Sure, yes, exactly.
They have done a better job perfecting the science where that's not happening as much, but you're right, I've taken care of people who do the selective reduction, and it's heartbreaking for them because they worked so hard to get pregnant and now they have to choose.
Yeah. So in Texas, many are like, they're shutting down. The IVF clinics have already started shutting down, and they won't even allow it.
Texas is pretty conservative, I think.
So is Missouri, they're starting it. They're having, it's the same legislation.
Interesting. No, I had not heard that.
Mhm.
Okay. So it's about legalizing or illegal, and IVF as a procedure in the state, okay.
Yeah.
So what does that do for, like, my sister did IVF for her 2 babies and she has 2 eggs left?
Good question.
Like,
There's not a good answer because now they're saying that if you destroy it, you're committing abortion.
well,
on
that's
the
her
fetus.
property.
Well, the
So-
thing is though, is her first child, she had to have a C-section because he was sunny side up is what she said. And then the second one, she had to do another C-section and she was in the ICU for 2 days and had 5 blood transfusions because she hemorrhaged.
Oh dear.
So now she's like terrified to get pregnant. She doesn't want to have any more kids because she was like on the, well, she's pregnant now, naturally. So, yeah, she's pregnant now
Oh, she's
naturally.
pregnant now naturally?
Yeah, she's having
Okay.
a literal come apart. But so yeah, she still has 2 eggs now, and there's
How far along is she?
she's due in March. I don't know how far that is.
8 weeks or so?
I don't know.
First trimester.
I just remember her telling me about it, yeah, and she's freaking out. So yeah, so she has 2 eggs left now, and she's obviously not going to use them. So
Yeah, I
She
think
didn't
that's
wanna really-
also
yeah.
Complicated.
It's very complicated. Here's where I think it gets even more complicated.
I don't know.
What do you think about genetic engineering? And who pays for that?
That's a no-no.
What'd you say?
I think that's a no-no.
But you're
Okay.
not a parent who carries a cystic fibrosis gene or a sickle cell anemia gene.
But like what she was saying, like,
I'm devil's advocate.
No, I think a lot of people, when they hear genetic engineering and they think of things like we're gonna be able to remove this horrible disease, I think a lot of people can get on board with that.
But
in concept.
where do you draw the line?
Where do you
about
draw the
blue
line?
eyes.
Of
I
what
Yes.
needs to change?
And a lot of people will say, a family with a lot of short men will say, this has been a problem my whole life, I don't want to. No, I'm serious.
You've been on Tinder, you don't know what's under 6 foot tall.
Are you guys, why are you laughing at me?
No, it's
because now there's surgery to extend your legs.
What?
Oh my god.
Yeah.
What'd you say?
You can do surgery to extend your
Oh.
legs.
That's
You
probably.
can
pays
even
for
get
that?
like 3 to 4 inches.
Yeah, but I would think a guy that's 5'1" is not gonna think that's gonna serve him as well.
I mean, if he's already 5'1", then only 3
Yeah.
inches, like 5'4" still isn't very tall.
I'm saying, so if you have an option, if it's been in the family.
Okay, how about male pattern baldness? Most guys I know that are bald wish they were not bald. But that's not deadly, right? So that's one of those things where that's expensive. So people who have the money, they can do it, but then what do you say to the people who say, well, why can't I remove these diseases from my, And that's the one I mean, we're just scratching the surface of genetic engineering. There's some programs where they basically say you're shopping for your child. I want blue eyes, and they will analyze your sperm and eggs submission, it's getting very high tech, And just because you haven't seen it or experienced it, it's around. So how does that look for children long term if we're buffering the human race? I've heard some people say too, with things like Down syndrome, they've said, we don't want to get rid of people with Down syndrome. Stop acting like that's a bad, So what some people think is a bad disease and they don't want, other people say, why would you remove these wonderful people from? Any thoughts?
None that are nice.
I think you should just not do it. Like, just keep doing what we're doing now. I don't know.
Stephanie, it's my right
I
to
know,
do it
I
with
don't
my
like-
money.
It's making me angry.
Yeah, it makes me
I feel like
there's no
that
aspect.
goes into just playing God.
Yeah, right.
What if you don't
Some
want
people
that?
don't do it.
Yeah.
What if I'm an atheist and I say, that doesn't bother me?
Yeah.
And that's why it's so hard to make laws at the state and federal level, because just in this room, I'm sure we have quite a diversity of views. And this is only, what, 18 people? No, I'm sorry, 17, 16. You guys are 15, right, and I'm 16. So, okay, any other thoughts? Good topics, difficult topics. I will say that just in the last few years, the circumcision one, the AAP, the American Academy of Pediatrics, sort of fixed that one, because the big debate was, should Medicaid pay for it? For people on Medicaid. So the AAP, and that's a big portion of the population, in my opinion, wrote a very genius recommendation that makes everyone happy, because it said, probably, yeah, it's something to the effect of, it is not, there's not enough research to say that it should be recommended for all babies. However, families that want it shouldn't be stopped from having it if that's their desire. It was something that was like a win-win for everyone.
There are indications that it does prevent
Yes,
further need for medical.
but not enough to recommend it
Yeah,
across
not
the
enough
board.
to recommend across the board, but it does prove to be
There's
beneficial.
some proven benefits, but not enough to recommend it every single. And then I thought the caveat was, but if families want it, it should be provided. So it's the way that we can then ensure it's being covered. So I thought that was relatively clever of them
Do
to
you
try to.
feel like circumcision has gone down? What do you see in the trends?
I feel like it, what I've always been told and what I've seen is in like central Missouri, it's always been very high. There's definitely parts of the country where it's very rare.
Oh, really?
My friend that I used to work with, she's like 40 something. She's got 3 kids, and 2 of them weren't, because they live in, she's from England, and they lived in England at the time, and it's not normal to get it done there.
Yeah.
But then the one that she had here, he ended up getting it done. And I just thought that was the weirdest thing ever, because here I feel like.
Oh, so she has 2 boys that are not and 1 that is?
Yes.
Oh.
And
Yeah.
our healthcare in Italy will not pay for circumcision.
I don't
What'd
think,
you say?
Our healthcare in Italy will not pay
Oh,
for
Italy.
circumcision.
yeah, I don't think England would either, because it wasn't a
Yeah.
preferred thing for them to
It's
do.
way more common in the US, and in the Midwest, it's way common.
Yeah, see, she lived
Like-
here, I think,
But like on the coast, it's not nearly as
Yeah.
common. So, I don't think I've noticed personally a lot of changes, because I feel like given our population in Missouri,
It's pretty.
there's a lot of,
pretty constant.
yeah, if you think about the male population and their belief system, I think it's one of those things that
It's so
Generations
into
have
our
done, and they're gonna keep
society.
doing. It's a difficult topic too, because I had a student one time when I was teaching in an LPN program, he was so against circumcision on babies. He thought it was so wrong. And he said it's like doing plastic surgery on a baby. And he just felt very strongly about it, and he made some good points. But then I've also talked to another student I had at Columbia College. He was in the Navy, and he said that,
Oh, no.
like, I guess in the military, they offer it for free if you want that, and when you're on like ships for long periods of times, that's not the best. So a lot of guys wish they had had it, but don't want to have it done, like all this stuff, and so he was like, have it done when they're babies, and like,
So they don't remember it.
yeah, and
That's
it's,
how, we had a family friend who their son was getting constant UTIs. He didn't have it, so we had to have it done when he was 9.
yes, yes.
And so he remembers having it
Sure.
done.
Yeah.
Whereas when you're a baby, it's, yeah.
And I see both sides of that. I think that's, I can see both sides, and then it's like, I know one pediatrician I worked with, he was wonderful. But when I was assisting him with one, he's of course for whatever the family wants. But he said if somebody's gonna have it done, that is the best time to have it done. Just, but it's like you can't talk to the child and ask what they would want. So yeah.
I have a question.
Yes.
Not to get off topic, but
I think we're off topic already.
why is it essential?
Why is it essential? You mean circumcision?
Yeah.
Well, it's not essential, but there's some research that says that it reduces the risks of certain types of cancer as well as UTIs. So there's some research supporting that, the benefit, but they say there's not enough to recommend it across the board. So it's not a required procedure, but when the AAP changed their stance, they're basically saying, we support that it has some benefits, but we're not at the point of saying we recommend it for all baby boys.
I'm just asking because I know some people feel very strongly about it, but because I remember it used to be recommended to stop the spread of STDs and HIV and AIDS,
Yes.
but they stopped saying that now.
Yes. Well, and it depends on, which area of the world you're in, what the healthcare system is like there, and what is being spread around that area of the world. One thing we're going to talk about is, for a while they were recommending no breastfeeding if you're HIV positive. Here in the US, they don't recommend that over in, so that's very different. So that may be part of just different locations in the world, what the going recommendation is. So. But it is not, to clarify what you just asked, it is not an essential procedure.
I really appreciate these conversations because I am working on opening my mind to others, and so hearing other people's arguments is always really helpful. So I'm really appreciative that we can hear it here instead of with the patient.
Yeah. What I've learned, I'm glad to work in healthcare because it's helped me to be more open-minded, and it's okay not to agree with everyone. We're not all going to agree, but I think to me the most important thing is, even if we know we differ on opinions, I learn a lot from talking to people who have different views than I do. That's why I brought up the two male students I had before about circumcision, just because it was so, they didn't know each other, they were in different programs, but it was just ironic here, because one of them, he really made me feel bad for thinking of circumcising my child. I thought, oh my gosh. And then the other one was like, why would you not do this? It's so disgusting to be a man with, it was just, he was really being forthright with his information about the Navy ship that he was on, but it was in a post-conference topic. But that's two very different people with very strong views, and I'm not gonna say one of them's wrong. So, these are difficult topics for sure. I hope that you guys do learn to seek out conversations with people that have different beliefs than you and aim to have them in a professional manner. I do learn a lot from people who have different beliefs than I do, because sometimes when you're only around certain belief systems, you don't know how to think differently. But even if you don't change your view, you can still have an expanded view. I used to show this video, and it's probably 10 or 12 years old now, but do you guys know who Mike Huckabee is? He was a presidential candidate in the last round of the preliminaries, Republican. He was the Arkansas governor, I think.
Sarah Huckabee's dad.
Yes, it's Sarah Huckabee's dad. So he's very conservative, against abortion. And he went on, you guys know who Jon Stewart is? Very funny, late night, okay. Mike Huckabee was the guest on his show at one time. And I believe Jon Stewart said, you pick the topic, let's discuss something. And so they picked abortion. And it is the best representation I've ever seen of two people with different views discussing probably the most hot button issue that exists in our society. And it's uplifting. And they're very respectful, and they talk it out, and they talk about how it's a hard issue. But I wish that everyone could talk about things like that, even if they don't agree, because they were respectful. So, anyways, yeah, I enjoy these discussions as well. I wish they had right answers, but they don't mostly have right answers. Okay, Family dynamics. I'll be forthright and tell you I'm not going to test you over these different types of families that are listed. But I think you guys know the concept of family has changed drastically in this country over the last 60 or 70 years. How so? What's changing?
6 years.
Okay,
Well, now it's more common to have 2 moms or 2 dads.
okay. So same-sex parent households, sure. What do you say? Okay, single parent household, so single parent with children, sure.
Blended families.
Lots of blended families, right? I remember last year when I was teaching GE 101, they had to post an introduction, and it caught my attention, I guess because I don't ever have you guys post them. But a lot of people were saying things like, I'm the second child on my mom's side and the 7th on my dad's side. A lot of people were saying it that way versus I'm used to thinking, oh, I'm the oldest of 2. But they were categorizing that on their mom's side, this is where they fell, on their dad's side. Because they had parents that were split apart, reblended, that kind of thing. So that was eye-opening to me, just to learn. I never have had to say it that way because my parents are still married. But what else? What is a person's family? What do we think of? I should say this. Historically, what do we think of as a family? Okay, we typically think there's a biological component, right? And what do we typically think of?
Mom, dad.
That's what we typically think of: mom, dad, and their children. Usually in one household, right? Okay. But that starts to change. We can add different generations. So sometimes grandma, great aunt, whatever, comes to live with them. But really, we're thinking of like the traditional nuclear family. A person's family is what they call their family. Okay, so if they bring in 4 people in the room and say, this is my family, that's their family. It doesn't matter what the relationships are.
I struggled with that when I first came to America because the idea of family was always, they called it immediate family.
Yes, yes.
So for a long time I didn't understand
Didn't know what that
because my cousins, my uncles are my immediate family.
And we think of that as extended family, probably.
Yeah,
You
and
might
someone
hear
will
that.
actually tell you like, oh, your uncle is sick, you cannot take time off work because of that.
Oh, gotcha. Yeah,
You'd be like, what do you mean?
and it's my uncle, right?
That's my
Yes.
family.
Yes.
Close.
I like to learn about perspectives of people when they come to the US and what they have to learn, just because.
I even have a hard time with that, cause like just with my family being so close, like whenever I have a family member die or even have something happy, you wanna be there.
Yeah. But other people would say, well, that's your cousin's uncle,
Right,
why do you
yeah.
care about that? Yeah, but they're comparing it to what they think of as their. Okay, so what I want, the reason I have this on here, I mean, family's important everywhere. Here is a tip for you. Don't ever, 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 ever in this specialty assume that you know when you walk in a room who the people are and how they're related. Do not ever assume that because there's a mom in the bed holding the baby and a male next to her that appears to be about her age, don't assume that's the father of the baby.
This is hard because.
It's very hard, yeah.
Like if somebody was the father and you're like, you just try to get
Well,
inside.
what I typically do, because once you know it's the father, then you can, but
Yeah.
you just don't want to make the mistake, because once you put your foot in your mouth, you'll never forget it. It's really hard to get out. I always started every shift when I would walk in a room, I would go over to the baby, look at the mom's, and then I would just say, now, how's everyone related in here? Or, if I saw the band and it was a male, I would typically
Do they not ban the fathers here?
any support person. So she can pick her mom, she can pick her sister. It's not always a
Is
father.
there still like limit on who all can come now with COVID and stuff?
I heard Cap Region is open. I believe. They've gone back and forth because my brother and his wife just had a baby in March at St. Mary's, and they were only allowed 2 total visitors
In the whole day.
the whole time they were
Yeah,
there.
that's how my sister.
So even if
yeah.
2 left, you couldn't have 2 new ones come.
Yeah, when my sister was in the ICU.
You are so
We couldn't, yeah, she was in the ICU and she was in Columbia and my mom and I couldn't even meet the baby because of it.
I think I think at St. Mary's we might be open now.
Okay,
Cause I know that on like the regular floors, at least anybody can go, but.
you never know what you have until it's gone. I felt
Yeah.
so sorry when people had babies right when COVID hit and they could have no one. I don't even think they could have their support or slippers.
In the room,
I don't think so.
Well,
It
it makes
depended,
sense,
it depended on the hospital.
But
There were
at
some
first, I
places
think
though,
some
there
said
were a lot of
no.
places where
But
no.
even like singular elderly people, like, you know,
Oh,
that
yeah.
are so confused and
Yes,
then
that's
the only
heartbreaking.
exception is that they're dying and I knew I had.
But even when
like,
COVID first happened, I don't think they were letting them in, even when they were dying.
Yeah, I don't think anybody.
People were dying.
Yeah. Aren't we glad that those days are hopefully?
Yeah.
Okay, so, the other thing, so with this, I'll give an example. I walked into a room one time and it was the mom's brother. I think he was just there visiting, but he was sitting in the chair next to the bed and it was just the 3 of them. So it was very easy for me to assume it was the father, right? And I'm glad I didn't get my foot in my mouth, but and I think maybe I already knew who the dad was. And so then later I was like, you know, another example is sometimes the father of the baby looks